Hi guys, welcome back. The topic that we're going to study now is multiple myeloma, also called as plasma cell dyschardia. And the first question that would be coming in your mind would be that why this multiple word is being used. Well, one of the reasons would be that this can be having myriad manifestations, but another one would be that it could be having a wide spectrum of presentation. I'll be describing terms before you that you have read in pathology as well, that is smoldering myeloma, monoclonal gammopathy of unknown significance, and even the word plasma cell leukemia. So keep tuned for the subsequent inputs that I'll be providing for these terms. But because of this wide expanse of terms that are going to be the presentation of the disease, we use the word multiple. So let's look at some background information. You are very well aware from your basic sciences that the antibodies would be having a heavy chain isotype as well as a light chain isotype. The heavy chain isotype would be having subsequent names that would be immunoglobulin G, then A, M, D, and E. And you very well know that the first line of defense in the body happens to be immunoglobulin A. Then in the antibody, we also have a light chain isotype. And the two isotypes that you need to remember would be kappa, and another one would be the lambda 1. And the basic problem in multiple myeloma, I'm putting a plus sign here to highlight the fact that the light chains will be overproduced. Well, there would be a couple of significances of this overproduction of the light chain. And the first basic problem would be that the antibodies which are produced in the body of this person are going to be defective. Because of this, the chances of this person developing infections will definitely be higher. So you will notice that the MCQ will say, what is the leading cause of death in multiple myeloma? You will be answering this as infection. There can be two possibilities. Either this person could be ending up with pneumococcal pneumonia or could be ending up with even pyelonephritis, which would be also referred in some MCQs as complicated UTI. The standard presentation would be fever. And along with that, person would also be having costovertebral tenderness. In fact, what I said is itself a question. Pyelonephritis per se would be presenting as costovertebral tenderness with along with subsequent development of features of even I would say sepsis and then septic shock that would be occurring in the person. Now, over and above this, one aspect that I know that you might be, sending me a message across is that, doctor, I have read in pathology that even renal failure is one of the leading, the statement is one of the leading causes of death. So yes, renal failure does occur in these patients primarily because of the fact that these light chains are going to go and block the tubules of the kidney. So you will notice in the subsequent part of the video me talking about tubular damage, me talking about tubular necrosis in these patients. So yes, renal failure plays an important component for contributing to mortality in these patients, but then you definitely can handle renal failure by planning either a renal replacement therapy in the form of hemodialysis or maybe even planning a transplantation for the person. So my point here is just to tell you the fact that when I compare two heavy duty causes for mortality in these patients, then in the MCQ, infection and renal failure both would be given, but your first answer would be given as infection, which would be difficult to treat since this person's inbuilt immunity is relatively lesser. Let's look at the second problem that will crop up in these patients, which is due to overproduction of these light chains. You very well know these light chains, when they come in the urine, they are referred as Benn's proteins. But because that's very baseline and primitive data, so I'm not introduced the term Benn's proteins except for a casual remark that I made right now, because you are aware of that from even your junior classes. So let's actually look at what does he expect from you in the exam. Let's look into and dive deep into the examiner's mind per se. So because the light chains will be produced much more than normal, this condition will also contribute to increase in the viscosity of blood. Now, I will be giving you definitions of what I mean by the word hyperviscosity syndrome, but the bottom line at the moment is that this will contribute to sluggish blood flow, and therefore you're gonna read regarding organ infarction in these patients. And when I say organ infarction, even when I look at the kidney, you have a cortex, you have a medulla. Medulla being deeper inside is more susceptible to infarction. So one more reason why renal failure can be one of the heavy duty causes I was saying for mortality in these patients is that there would be a kidney infarction, there would be a medullary infarction, and medulla is where the tubules of the kidney are located. These proteins are positively charged. So if you're going to check the urine protein of this person by a dipstick method, the dipstick will turn false negative. Why? Because the dipstick is designed to pick up albumin. Whereas this person is not having albumin in the urine, he's rather having positively charged proteins in the urine, and therefore the technical term that we will also use in books and in multiple choice questions would be paraproteinemia, and this will also impact the anion gap of the patient. So when I come to the investigations component, you would hear me talking about anion gap, because traditionally we read about anion gap in diabetic ketoacidosis. I've described terms like HAGMA, NAGMA, that is high anion gap metabolic acidosis for diabetic ketoacidosis, NAGMA for renal tubular acidosis. The point is that's discussed in ABG video, but why am I talking about this here is because there would also be impact on the anion gap per se. So if you can at this moment recall what's going to happen to the anion gap, great. If not, don't worry. I mean, I'll definitely handle it. I'll fix it subsequently in the workup of these patients also. But two fundamental problems that I've described from the overproduction of light chains would be that antibodies produced here are of defective type, and there's a hyperviscosity that is occurring in these patients. And as these plasma cells will colonize the bone marrow, they will start producing lytic lesions in the bones. So every time you read a question regarding lytic lesions which are going to be present in the spine, then subsequently in the pelvis of the person, in the ribs of the person, and then subsequently even the skull. I mean, all of you know that lytic lesions present in X-ray skull of an old man, the classical raindrop configuration is going to be multiple myeloma. But make no mistake, the lytic lesions, the commonest site for them is not the skull. It is actually the vertebra. So you will read about and will listen to me talking about an old man with low back pain, and I thought that he was having maybe a disc prolapse. I thought maybe he was having osteoporotic lesions, which is contributing to a degenerative spine disease, but turned out that he was having these lytic lesions secondary to multiple myeloma. So what I've also done here is show you a quick image here, and in the question if he says what is the best imaging modality, mark my words there, I'm not saying what is the investigational choice for multiple myeloma. That's my job to teach you. What I'm simply saying is that if he says what is the imaging modality that you would like to use to identify the lytic lesions which are present at multiple sites, then yes, obviously X-ray can be done, a CT can be done, but even an MRI can be done. But in fact, to identify the disease focus, to identify, because the disease is originating in the bone marrow, the best test would be answered as a PET CT. So I repeat my statement again. Yes, radiological findings will be seen, but they'll be seen very late. And I really don't want to wait for the lytic lesions in the person to appear and then tell him, okay, you have multiple myeloma. I want to pick up the disease focus initially. So primarily when he says, what is the imaging modality of choice for multiple myeloma, he wants to see that are you aware of the fact that you can identify disease focus, and all these black spots that you're seeing is where the uptake of 18-fluorodeoxyglucose is relatively increased. Now before I go forwards, I want to also add two important more informations to this particular slide. One of them is going to be that can we actually measure the light chains in the urine of a person, because as I said, dipsticks are going to be turning out to be false negative. So the query in your mind would be that, okay, if dipstick is not going to identify it, then how are we going to measure it? And even if we say, okay, proteinuria is present, no big deal. I mean, we need to quantify, is it light chains which are contributing to this? So we are now capable of doing what is called as a light chain assay, and they can ask you in the exam that how much is the excretion of light chains in urine of a normal person. If you will listen to my kidney discussion, you will hear me saying that albumin is present in urine of normal people. Yes guys, albumin is present in urine of normal people. The amount is less than 30 milligram on a 24-hour basis, 30. Look at the value that I highlight here. Light chains are also present in urine of a normal individual. That would be less than 10 milligrams per day. So I can definitely do a quantitative test that would tell me what is the magnitude of light chains, what is the magnitude of paraproteins, because as I explained to you, these light chains are positively charged proteins in contrast to albumin, which is going to be negatively charged. So let's look at what is the important triad for diagnosis of multiple myeloma. And one of the important features that I want to highlight at the moment is that if you're going to do a bone marrow biopsy in these patients, then it will say bone marrow biopsy of the patient shows plasma cytosis. The plasma cells in the bone marrow should be in the range of more than 10%. The moment I say that, the query from your side would be, sir, in pathology we have read 60%, you are saying 10%. Well, first I'm quoting Harrison here for the fact that there are two separate expressions. One of the expressions is going to be plasma cell percentage. Second is absolute plasma cell value. Both are mathematically separate. So when I say the word plasma cell percentage in the bone marrow more than 60%, that's definitely a feature of multiple myeloma. If I don't use the word plasma cell percentage, I say absolute value, it is 10%. You will say, sir, it is so confusing. What should we answer in the exam? Then in the exam, you will answer a triad, because one single feature is not going to be diagnostic of multiple myeloma. You actually need to have a combination of plasma cell in the bone marrow more than 10%. And because there is going to be excessive proteins in the blood, so I'm going to do a test called as serum protein electrophoresis. When I do this electrophoresis, I will be able to demonstrate what is called as M spike. And because all these proteins in the blood are going to come in the urine of the person also, so sometimes the MCQ might say urinary protein electrophoresis. So SPEP is serum protein electrophoresis, UPEP is urinary protein electrophoresis, showing a presence of a M spike. And M here does not mean that it's going to be some M alphabet shaped spike present. It simply means a monoclonal component. It means the antibodies which are present in this disease are going to be monoclonal antibodies. And I'll be demonstrating two techniques before you subsequently also, by which we are able to demonstrate this monoclonal spike, which is techniques like immunoelectrophoresis and immunofixation, which can be given as image-based questions to you. The third important feature for diagnosis of multiple myeloma would be features of CRAB. CRAB would mean hypercalcemia, renal failure, anemia, and bleeding. Though I described the mnemonic CRAB at the moment, I've not written it, because in the textbook you will notice he's not going to write the word CRAB. He's going to just describe clinical features as myeloma like events per se. So if you're going to be having these three things given in a question together, that's when you're going to answer this is multiple myeloma. I want to tell you right at this particular point of the discussion, though even right at the end of the discussion, I'm going to come back to this diagnostic triad. If hypercalcemia, renal failure, anemia, and bony lytic lesions, if they're not developed in a person, will I wait for them to appear to say, okay, I need these for you, I need you to suffer, and then I'll make a diagnosis? The point is, every patient would say, sir, I need an early diagnosis. So I want to tell you that if these myeloma-like events have not occurred in the patient, then what is the cutoff to be present to the plasma cells in the bone marrow for diagnosis? The cutoff is 60%. I hope, guys, now it makes much more sense. I am saying that if myeloma-like events have occurred in a person, if features of CRAB, renal failure have already occurred in the patient, the cutoff required is relatively less. But on the other hand, if clinical features are not present, if you just need one laboratory evidence, then it is a plasma cell percentage in the bone marrow more than 60% for diagnosis. And I'm very sure that these points will become even much more clearer as we progress in the discussion. But at this moment, I would like to rate this particular triad as the most important part of the discussion per se, because everything that I'm going to say subsequently for terms like monoclonal gammopathy of unknown significance, I know longish term, it causes a bit of distress initially, but MGUS, smoldering myeloma, all of those terms are based on this fundamental definition that I have explained to you. And now I'll be showing you two techniques by which we are able to demonstrate this M spike. Now, as I've explained to you, the word M spike here would mean that this would be monoclonal antibodies being produced. So what he has asked in the exam is also the fact that what should be the tumor load present in this patient to cause these monoclonal antibodies to turn positive. So the number of tumor cells present in the bone marrow should be more than 10 raised to power 9. You can see, I would say, megatrillion tumor cells. This is the basic minimum tumor load that is required to contribute to development of this M spike. And then I've shown you two techniques which you can very well identify from your background classes also. The first one, where I have shown relatively a reddish representation, would be immunoelectrophoresis. Now, electrophoresis would help you identify whether it's going to be a I would say albumin, whether it's going to be globulin. But then you have subtypes of globulin also, that is like alpha, beta, gamma. So gamma globulin is obviously the antibody component, and you will notice a big spike present. You can anyway see an arrow present here. This arrow is pointing towards. It's also rather this arrow might also be written in some books as church spire. Like I would say, like just like on a church, there would be, the building of a church per se might be having a very pointed tip on the top, the roof of it. So similarly here, the church spire appearance or M spike is a term used to describe this, would be immunoelectrophoresis report of a person. And I would also like to tell you that for details of interpretation of immunoelectrophoresis, if you're looking for that, because here I have to cover multiple myeloma, so details of immunoelectrophoresis interpretation are covered in the topic of cirrhosis. Why in cirrhosis? Because in cirrhosis per se, what happens is that the catabolism of globulin becomes lesser, so therefore globulins can also be increased in patients with cirrhosis. But for that, you'll have to anyway listen to the cirrhosis lecture per se. So at the moment, I just want to say that the superior technique here is immunoelectrophoresis. And if you look at the inferior report, here I am subtyping what type of immunoglobulin is present. So the second technique that I have shown here before you is called as immunofixation. Now, the advantage of this immunofixation would be that it will not only tell you that it is the gamma globulin component that is increased, it will also tell you the fact that in this patient, which subtype of the light chain is being overproduced. Like you can see in the representation that I've shown, it is rather the lambda subtype, which is relatively increased in amount. So, immunoelectrophoresis and immunofixation can be given as image-based questions to you, and they definitely help you in identifying multiple myeloma. And in fact, the most common antibody which is defective in these patients is immunoglobulin G subtype. I repeat the fact once again. I began the discussion by teaching you that it's gonna be infections which are the leading cause of mortality. At the moment, I've just highlighted that immunoglobulin G subclass of antibodies is the one which is produced defective in these patients. We shall now be talking regarding etiology of development of multiple myeloma. The first risk factor that I want you to remember is exposure to radiation. In fact, almost all blood cancers or hematological malignancies can be ascribed to radiation exposure except for CLL, and has been discussed a couple of times. The next etiology that I want you to remember here will look very surprising when I write it initially before you. That would be woodworkers and farm workers. And your query would be, sir, I mean woodworkers, farm workers, how that is so? So I want to tell you that both of these would be having exposure to petrochemicals. Now, like a woodwork worker might be actually exposed to turpentine oil and other chemicals which are used. So petrochemical exposure has been documented to contribute to development of multiple myeloma. Then would be aspects related to chromosomes. So a bit of cramming to be done from the chromosomal perspective. And you will notice that number 14 will come again and again. That would be 13q14. You also read about 13q14 with respect to retinoblastoma. Then is a chromosomal swap, that is 1114. Then is 414. And the third one to be remembered would be T14:16. This is identical to what I would say is what I have described even in non-Hodgkin's lymphoma with respect to Burkitt's lymphoma. You very well know that in Burkitt's lymphoma it would be 814, then 822 and 28. These are the important chromosomal translocations that are asked, and number 8 was being repeated again and again in Burkitt's lymphoma. B alphabet would look a little like 8, I would say. So that's how you can remember it. And with respect to multiple myeloma, it's chromosome 14 that has been repeated a couple of times. The next aspect to be remembered would be a deletion related to chromosome 17p. Then is gonna be related to chromosome 1. It's gonna be 1p amplification. Now this requires, I would say, a bit of a superhuman effort to remember. That would be 1p amplification and then a 1q deletion. And there's a high possibility of error that or high possibility of inducing error, I would say, on the part of a student, because he can switch this data. So there is a possibility that he might say all are related to multiple myeloma except, and 1p and 1q will very much be there, but the data might be replaced by like a 1p deletion and then a 1q amplification. So do take good care to ensure that this error of judgment does not occur. And ultimately, because of all these risk factors that I have described before you, there would be myeloma cells which are gonna contribute to overproduction of the light chains, and therefore you would be having a defective antibody production. Apart from this, there are also bony lytic lesions which are developing in these patients, for which I said I'm not going to wait for the lytic lesions to develop and then say, okay, the diagnosis is made. I can go even early to pick up the disease focus by doing a PET CT in the patient. Now, what are these myeloma cells actually producing? That there is a damage to the bone of the patient. So they're activating the osteoclasts per se, and as a result of it, the bone destruction would be occurring. This also tells you the fact that why in all MCQs of multiple myeloma would they love to ask you about serum alkaline phosphatase, because serum alkaline phosphatase is not related to osteoclast. Serum alkaline phosphatase is directly related to osteoblastic activity, And what I taught you was that in multiple myeloma, it is not a osteoblastic activity that is increased. Osteoblastic activity is normal. SAP is related to osteoblastic activity. The activity is normal, so SAP is normal. What is increased in these patients is the activity of osteoclast, so the bone destruction will occur. And he will here ask you what is the cytokine, which is actually the main villain being produced here. So the cytokine that is being produced here, you would have read that even in pathology books, is MIP-1 alpha. The full name would be macrophage inflammatory protein, and this is the main culprit which contributes to bone damage. And why it is important is because when I was a student your age, we mainly used to read regarding interleukin 6 being responsible, but currently you will notice in the current edition of both, I mean the pathology books and medicine books, he is rather talking about MIP-1 alpha, that is macrophage inflammatory protein, which is responsible for these lytic lesions, and also explains why bone pain is the commonest presentation that will occur in these patients. It's initially the vertebra and also is the most common site, then is the pelvis, and it's in the later part of the illness that the skull would be getting involved. And because of these lytic lesions, even the breakdown of bone will anyway contribute to production of calcium. So you will be having hypercalcemia developing in these patients. Because it's a chronic disorder, so amyloidosis will also occur. And both of these factors that I've written at the moment on the slide, hypercalcemia due to bone destruction, amyloidosis because anyway we are talking about association with AA variety of amyloidosis which can damage the kidney. So two reasons have been enumerated why the kidney in these patients was discussed initially as one of the organs bearing the brunt of the disease. I mean the disease, why he's asking is because the disease is in the bone marrow and it's the kidney that is suffering. Over and above this, infections will also contribute to this. As I told you, I mean pyelonephritis can contribute to scarring of the kidney. And because of the bone pain component, the person will be using painkillers on regular basis. I mean, I said lytic lesions will contribute to bone pain, so person will use painkiller. The painkiller on a regular basis will be affecting the prostaglandins, because the prostaglandins are the one which help in maintenance of the gradient in the kidney for filtration. And because the prostaglandin production in this case is also getting hampered, so the perfusion of the kidney will definitely be lesser. The filtration component will also be hampered. So you can see there are various reasons why I said that the kidney gets involved. It is hypercalcemia, amyloidosis, infection, and even painkillers which contribute to I would say the kidney getting involved in patients of multiple myeloma. And they love to ask about it. Why? Because after all the disease is in the bone marrow, and as I said, the kidney is getting involved. Over and above this, the viscosity of plasma is also getting increased. So we need to have a look at a definition of the word hyperviscosity. So let's look at some normal data once again. Like I taught you that we can be having light chains in urine of a normal person less than 10 milligram. Now I'm telling you what is the normal viscosity of the plasma. And as they say, blood is thicker than water. I mean, the normal saying is blood is thicker than water. So I can just say that the normal plasma viscosity would be 1.8 times more as compared to the viscosity of water. Why they're using viscosity? I mean, water as a baseline is only the fact that you see, water will be one of the common things that's available everywhere. So you can use it as a standard baseline value. I repeat the fact once again, in a normal person, the plasma osmolality is little less than 2 times. I said 1.8x the viscosity of water per se. Now, when I say the word hyperviscosity syndrome, hyperviscosity is what you will read in polycythemia vera and you will read in multiple myeloma. The cutoff which is to be remembered for the exam would be that the viscosity of the plasma should now be at least 4x, almost more than double. Remember I told you almost double, 1.8. If the viscosity of the plasma is mentioned in a question, or if he says before you what is definition of the word hyperviscosity, it is 4 times heavier than the, or 4 times more than the viscosity of water, you will say it is hyperviscosity syndrome. This will explain the fact why sluggish circulation and organ infarction would be occurring in these patients. One more reason, the kidney is getting involved. And over and above these patients are also said to be suffering from hypogammaglobulinemia. And while I'm writing it, I do get a lot of pings from students. Sir, on one hand, you are saying that antibodies are being overproduced. Now you are saying that there is a hypogammaglobulinemia. So listen to my description very carefully. I never ever said antibodies are being produced. I said light chains of antibodies. I never said antibodies. I said light chains of antibodies are being produced, overproduced, and therefore the antibodies are ultimately defective. So this that I'm writing at the moment, I hope it makes more sense now. These patients are not having normal antibody profile. They are rather having hypogammaglobulinemia. One of the reasons for hypogammaglobulinemia, as I explained to you, was the fact that, there's a defective antibody production. Second is also documented that the catabolic rate of destruction. Whenever you say catabolic, it's after all gonna be causing destruction. Anabolic means product formation. So catabolic rate of the antibodies or the defective antibodies is also increased in this patient. So this statement is again to be remembered, because it's no big deal that if you miss the word overproduction of light chain, the light chain word is missed, you might get an impression as if antibody is being produced more. So in this condition, the good antibody is definitely scarce. It is the light chains, the paraproteins, which are being produced in large amount, and because of this, I explained already that the infection chances will be dramatically increased in these patients. Another hematological feature will also occur. This hematological feature, that's gonna take some time to appear, so I'll just write it on this slide only, would be a development of normocytic normochromic anemia. Now let's look at why that is happening. You see, what's happening is that the plasma cells are multiplying again and again and again. So if the plasma cells will colonize on the bone marrow, then other cells in the bone marrow like normoblast will not be having a sufficient amount of space and nutrition to multiply. So there would be an anemia component that would be coming up. So we call it normocytic normochromic anemia. Along with this, you can also be having bleeding in these patients. Now, what is the reason for that? The reason for bleeding is that if plasma cells will colonize everything, then the biggest cell in the bone marrow, is megakaryoblast. That megakaryoblast will not be having space to multiply. As a result of it, this poor fellow, the megakaryoblast, will not be able to generate sufficient amount of platelets. So we always find platelet count to be lower in patients of multiple myeloma, and some of the defective antibodies might actually also cause an accelerated clearance also. So antibody coated platelets, I repeat once again, antibody coated platelets are also documented in these patients. So lots of things happening on this slide. Let's just practice that once again so that we can remember the aspects here. In fact, I'll just put a pointer here to also highlight what are the important things which you must understand from the pathophysiology perspective for the disease. Point number one, there would be lytic lesions in the bones of these patients starting from the vertebra and the pelvis. What is responsible for it? MIP-1 alpha. That's the first point to be remembered. Second, you have kidney damage, multiple reasons in these patients. If he asks you the first cause, you will always notice whenever I write information, I always write it in decreasing order of importance. I told you multiple reasons for kidney getting involved. It was not only hypercalcemia, it was amyloidosis, infections, NSAIDs, hyperviscosity syndrome, all of them contributing to damage. But the first one is hypercalcemia. Apart from this, hyperviscosity itself is a feature that can be asked. The reason for anemia, as I said, was that the cells, normoblasts, are not getting sufficient space to multiply, and antibodies could either be having I would say the defective antibodies could be causing destruction of its own platelets, something akin to, I would say, idiopathic thrombocytopenia, not exactly ITP, but I would say something akin to idiopathic thrombocytopenia purpura. So petechiae and purpuras can also be written in a MCQ of multiple myeloma. And the most important statement which I want to say after all this aspects that I've said is, in spite of all these aspects that we have talked about with respect to antibodies, I said it is hypo, not hyper. It is hypogammaglobulinemia, primarily because of increased catabolic rate and defective antibody production. And based on this information, what I'll do next would be just summarize the clinical manifestations of these patients, though I'll be giving you the exact I would say timeline of how the symptoms evolve in a person, but this that I'm writing at the moment will form the crux of the discussion of the timeline of symptom development in multiple myeloma. That would be CRAB. The bony lytic lesions, MIP-1 alpha, as I explained to you, will contribute to hypercalcemia. Very standard. The values usually given will be in the range of about 10 to 11, maybe going up to 12-13 mg/%. Higher is the calcium values, you very well know, chances of systolic arrest of the heart are dramatically increased. Then there could be renal failure. We have debated the causes behind it, hypercalcemia being the leading one. Alphabet A would stand for anemia and B would stand for bony lytic lesions, but don't remember, bleeding can also occur. though obviously that will take some time, it will happen in the later part of the disease. Prior to that, all these manifestations would have already appeared in the patient, but CRAB is written in multiple choice questions as myeloma-like events. And again, for diagnosis of these patients, I don't need all of these to appear. The importance of remembering CRAB is not only the fact that you need to know the full form. I am saying you don't need to develop all of these to say, okay, now multiple myeloma diagnosis to be considered because plasma cells are elevated in the bone marrow. Cutoff I've told you already. With myeloma-like events, it has to be 10%. So any one of these, if written in a question, you will make a diagnosis of the patient based on the triad that I highlighted as that of multiple myeloma. And now let's look at the timeline of how the features will evolve over time in the case. Now coming to the timeline, I am here describing a 70-year-old person, and he has come to me with complaints of bone pain, and this would be primarily because of the low backache that he's enduring for a while. He has been taking painkillers for it. He has already shown to an orthopedic surgeon. He has already been to 2 or 3 doctors before he has, let me say, come to me, because our patients anyway have a habit of doctor shopping, and common causes like osteoporosis, disc prolapse, metastasis to the spine with respect to carcinoma prostate, because I said a male patient, so carcinoma prostate anyway has to be ruled out. All that basic workup has been done. What at the moment I know is that he has suffered from a fracture of the vertebra, and this could be severe enough to even cause neurological presentation. He might actually begin the question by describing this low backache progressing to development of even paraplegia. So compressive myelopathy can occur in these patients. If he decides to mention about a paraplegia manifestation, you very well can understand. You might start thinking in terms of diseases like CIDP or AIDP, which are variants of Guillain-Barré syndrome. It is spine that is more commonly involved, though even pelvis can be involved in these patients, ribs can be involved, and it is in the last that the skull gets involved, as I've highlighted earlier. This old person also says that I get tired very soon. That's because of the anemia component which is coming in, and in the textbook it is mentioned that sometimes the anemia can be so bad. Look at the magnitude of anemia. I'm saying that it can contribute this chap to go into congestive heart failure. Initially it could be compensated, but later on there could be even a pedal edema developing in this chap because of decompensated heart failure. Because the kidney is getting involved, uremia features could be described. Now let me just jot down a couple of uremia features here before you. Obviously encephalopathy can occur any day if the kidney is involved, but initially urea is not getting excreted the normal way, like in our body via urine. The urea is getting excreted via the sweat. So when the sweat will evaporate, the crystalline deposit of urea on the skin will cause a bad smell to come to from this patient. That would be a uremic frost. And later on, because urea can definitely contribute to damage to the brain, in a sense that it's anything in excess is anyway becoming a toxin. So asterixis can develop, metabolic encephalopathy will ensue in these patients in the long run, and our objective is obviously to pick up the case relatively early. Hyperviscosity syndrome can be described as dizzy spells. He might undergo a cardiac workup for dizzy spells. We might think that he's having dizziness and vertigo because of heart blocks, but the ECG is turning out to be normal. It is only later we realized that it was hyperviscosity, though we were hunting for the pathology in the heart of this person. The pallor component will increase, bleeding manifestations will occur. It could be epistaxis, hematochezia, and depending on the platelet count becoming lesser, there could even be CNS features. Another feature that they love to describe for this particular case would be presence of carpal tunnel syndrome. And carpal tunnel syndrome is what you read with multiple other causes also. So let me just enumerate them before you, though I know it's very cliche, but still, as a physician, whenever I read this word, median nerve involvement, ape thumb involvement, it's just irresistible to not move ahead without talking about these words. You could be having a IT professional who's having carpal tunnel, pregnancy, then hypothyroidism, acromegaly, and even the topic that we're studying today, which could contribute to development of carpal tunnel syndrome in a patient, mainly with respect to the AA type of amyloidosis. Why this carpal tunnel syndrome is mentioned here, I hope you could pick up. It is the amyloidosis component which is contributing to this, and amyloidosis can contribute to macroglossia also. So the basic message is he would love to talk mainly in the MCQ in the clinical profile and would rather waste your time by making you think that this low backache and bone pain is maybe due to meds, maybe due to osteoporosis, and then he'll talk about deranged KFT in the person. He will talk about presence of anemia in this patient, and the anemia can be so bad that it can even cause development of congestive heart failure. So let's look at the workup that I'll be doing in this geriatric age patient so that I can be closer to my diagnosis. The first thing that I'll do in any hematological case would be to go ahead with the complete blood count. And when the report will come, I will notice that every time CBC report is given, even ESR report is given. And the ESR of these patients of multiple myeloma will be dramatically high. I mean, you would have seen ESR going up to 60, 70, 80 in a case of tuberculosis. Even in some cases of vasculitis, the ESR can be increased, but this MCQ will shock you by saying ESR of 100 millimeter fall in the first hour. I mean, you don't read about this outrageously, I would say, high erythrocyte sedimentation rate being given routinely. Diseases where you will read about this outrageously elevated erythrocyte sedimentation rate would be giant cell arteritis, then would be subacute bacterial endocarditis, and the topic of interest, multiple myeloma. You will realize the fact, though this initially will look, the ESR being increased, Rulex formation described in a question, they will sound like very harmless, innocuous things. But later on, you will realize that these are the words which are helping you clinching the diagnosis of this person. Because suppose it gives you a scenario of an old man with anemia with low backache and the peripheral smear is showing Rulex formation, the clumping of RBCs on the top of each other like a stack of coins, you have to consider this disease that we're studying as one of the differential diagnoses. Now, there is also possibility that if the diagnosis is made late, then the disease might get converted into what is called as plasma cell leukemia. You see, I started the discussion by saying that there is going to be increase of plasma cells in the bone marrow, but now they have colonized and they have taken over whole of the bone marrow and now come in the bloodstream also. So when you read regarding plasma cell leukemia, he will ask you about the definition. Your answer would be that if the plasma cells, and listen to this cutoff carefully, plasma cells in the peripheral blood, if there are more than 2000 such documented per microliter, you will say that this chap is suffering from plasma cell leukemia, which is one step above multiple myeloma. The disease has now gone into a ultra aggressive mode. The second test that I'll do in this patient would be albumin globulin ratio. And because when I look at this ratio, I mean, the values will definitely be affected because it's mainly the gamma globulin component. The mathematical value of it will increase, though they are positively charged proteins. When I check out the KFT, the serum creatinine as well as the creatinine clearance will be deranged. To pick up the bony lytic lesions, I can be doing a MRI and if possible a PET CT. I mean, though both can be given in the options, it's just the fact that a PET CT would be answered first in the MCQ from a diagnostic yield perspective. This helps you not only diagnose lytic lesions, which will occur later, they also help you pick up a disease focus. The next investigation that I'm gonna say for this person is important because there can be bleeding. So coagulogram will be done and even anion gap will be mentioned in the MCQ. So lots of time the question on this topic will be long. And what are the points that you need to pick up? You will pick up this old man will be having normal serum alkaline phosphatase. I gave you an explanation earlier. SAP is dependent on osteoblast. And what is increased in the body of this patient? Osteoclastic activity thanks to MIP1 alpha. So SAP is a good, I would say, though it's a very harmless sounding test, serum alkaline phosphatase normal. I mean, normal can never be a diagnostic criteria. I'm not saying that SAP normal is a diagnostic criteria for multiple myeloma. What I'm teaching you is that this question could actually be a very long stem question and you would get lost in large amount of data. But every time you read about an old man, back pain, lytic lesions, anemia, and then he starts talking about SAP being normal and ESR being grossly elevated, believe me, you will be able to crack a lot of questions of multiple myeloma, not because they will talk about lytic lesions in the skull, because I think those days are gone when they used to ask about it. So you would be rather be able to crack them on the basis of the aspect that I said, anemia, renal failure involvement occurring in these patients, and then two laboratory parameters, very harmless sounding, SAP being normal, ESR of 100, are good pickup points which must be given due respect, because otherwise if you go through the stem of the question, it will take almost 2 minutes to read the question itself. Then he would love to trouble you in the options with the value of anion gap. Now let's look at the formula for anion gap once again. It is positive charges in the body, and from that you will be subtracting the negative charges in the body. Negative would be bicarbonate and chloride. Now my point is that in these patients it is paraproteins which are elevated. Now whatever I'm writing at the moment, please don't note down, just listen to the mathematics here. Paraproteins are elevated, which means that there's going to be more positive charges in the body. I put a lot of plus signs here to say positive charges in the body is more. So now the kidney will act like a protective mother, and this kidney is going to say, oh, there are so much positive charges, let me try to neutralize them by increasing the negative charges in the body. One of the basic functions of the human kidney is to maintain electron neutrality. If by some freak event of nature like hair, radiation exposure or chromosomal abnormalities have caused multiple myeloma, positive charges are increasing, the kidney, like a good protective mother, will try to increase the negative charges. That is, it will try to increase the urinary reabsorption of chloride. In patients of multiple myeloma, because positive charges are more, the body will try to counteract that, counterbalance that by increasing the negative charges in the body. And when you increase the negative charges, now focus only on this formula, it is positive minus negative charges. If positive charges, that is sodium values are not changing. I'm here by positive charges, I don't mean that I'm incorporating the positive charges of paraproteins in the formula. No, it's not positive charges that are being incorporated. It is sodium value is the same. But chloride will be increased thanks to the help of the kidney, which is trying to neutralize and balance these paraproteins. So if chloride will be elevated, mathematically speaking, this value of anion gap will be lesser. This is an important point from the MCQ perspective, guys. So give this point a due respect that it deserves. A reduced anion gap. There is increased anion gap in diabetic ketoacidosis. It can be normal in like renal tubular acidosis, but when it comes to a patient who's having multiple myeloma, the anion gap values will be given to be lesser than normal. And this, again, I would rate it as an important point over and above normal serum alkaline phosphatase and gross elevations of erythrocyte sedimentation rate for this patient. Now, if he asks you in the exam, what is the screening test for diagnosis of multiple myeloma? Your answer would be that I'll go in for a urinary protein electrophoresis. If available, always prefer serum protein electrophoresis. I've just underlined that to give importance to the statement, and you would be able to demonstrate the M spike, which means monoclonal component, and the immunofixation would anyway help you know regarding the subtype of light chain that is being produced in a relatively large amount. So I've already explained and shown you the image with respect to immunofixation. The eighth investigation that I'll do will be not very important from diagnostic purposes, but he would just like to see that are you remembering the entire table of CD markers in flow cytometry. For plasma cell, the flow cytometric marker that would be expressed would be CD 138. Then I can go in for both a urinary as well as a serum light chain assay. I have already explained to you that we can quantify the light chains in the urine of a person, even in the serum of the patient as well. And as the blood values will increase, why I wrote serum here is because first blood values will increase, no? And then subsequently the urine values will also increase. The 10th investigation is again important. This has been asked in ANICET a couple of times, even in the FMG exam a couple of times, that what is the test that will tell you regarding the prognosis of these patients. In the options, he will also write serum beta-2 transferrin. Now, you very well know serum beta-2 transferrin is in CSF. It is serum beta-2 microglobulin levels, which will help you in determining the prognosis of these patients. We will also talk about the prognostic index that is being used at the moment. We don't use Salmon-Urey at the moment. As you would be aware, we use the International Prognostic Score. There are online calculators for that. So I'm going to talk about that score subsequently. But at the moment, I just included this point. Beta-2 microglobulin in the urine would help you determine the prognosis of these patients. Point number 11 is just for completion. Since I was talking about amyloid being or amyloidosis developing in these patients, the kidney of the patient will also get involved. To demonstrate the amyloidosis component, I'll not go for a kidney biopsy. You very well are aware that for amyloidosis, we go in for a fat PET biopsy. Fish would just let me know regarding the prognosis of these patients, because you see, some chromosomal translocations will always be associated with bad prognosis, or I would say some of them would be having cancer is always bad. It's just that we tend to categorize as doctors into worst scenario and I would say a relatively a better scenario. So like chromosome number 17 prognosis is always bad. The investigational choice for these patients would be a bone marrow biopsy, and you need combination of bone marrow biopsy with the clinical features of CRAB that I've explained to you and serum protein electrophoresis. I mean, you need three things together in MCQ: CRAB features, anyone, serum protein electrophoresis, and bone marrow biopsy report of plasma cells more than 10% to say that the triad is being satisfied. And at this junction, he can ask some aspects from pathology as well. From the pathology perspective, you will always notice that the myeloma cell will be having an eccentric nucleus. The nucleus will be present a little on the periphery. And in fact, it looks as if the cell is suffering from acne, because what you are seeing at the moment is presence of Russell bodies. These Russell bodies are inclusions, which are inclusions of the light chains inside the cells. And in fact, these inclusions, I'll just use a different color to highlight that sometimes these inclusions could be developing even inside the nucleus. Now I'm just going to use a different color to highlight it, but my point is you could be having both intranuclear as well as intracytoplasmic inclusions in these patients. Let me just jot down the histopathological features which are to be remembered. The cytoplasm you can see is relatively more blue, so basophilic cytoplasm with eccentric nucleus. In fact, the nucleus has one more characteristic that you guys can even, if I just minimize the slide, you can see the numbers written there. So I hope all of you are remembering from pathology class now. Clock phase chromatin. Let me just represent this once I've jotted down the baseline data. Basophilic cytoplasm, you can see it's blue. The nucleus is relatively eccentric. The intranuclear inclusion body, and you are having intracytoplasmic. The intranuclear one which is present here would be referred to as Dutcher body, and the one which is present intracytoplasmic is relatively easy. I mean, even in the initial chapters of Robbins, it is described that intracytoplasmic inclusions in the plasma cells in the bone marrow are referred to as Russell bodies per se. I mean, even in the chapter of intracellular inclusions, he has described it. This cell, which is supposed to be having or looking like having acne, is also called as a Mott cell. And if I just move the image a little superiorly, you will notice that in the nucleus, let's look at this cell here, then the nucleus is eccentric, and the chromatin material is usually present eccentrically. The one that I've highlighted at the moment is the chromatin material. I'll just put an arrow for the same, the blue dot that you can see, and this is present as if the clock is actually being simulated here. I mean, just very precise 12 o'clock, 3 o'clock, 6 o'clock or 9 o'clock precisions. So this is anyway a high power view, I would say. So the textbook will always use this word, clock phase chromatin. Whenever questions on this topic will come, it will be a long stem question, and they will try to mix up the information of pathology from medicine. So I thought that though you guys are very much familiar with whatever I've said in this particular part of the slide, but I thought I'll just repeat it for your convenience so that at one single place you have a data and you can remember it. Then another feature that they can mix at this particular point of type in multiple choice question can be an X-ray skull finding of these patients. I did not write that X-ray skull in the workup of these patients primarily because I have already highlighted that the imaging modality of choice for these patients, in fact, point number 14, which can be added here just as a retrospective, is imaging modality which can be done to identify the lytic lesions would be a PET-CT. If X-ray skull is given, he will always use the word raindrop lesions, because lytic lesions can be present even in osteopetrosis. I repeat again, you can be having X-ray skull where lytic lesions can be present even in osteopetrosis. In fact, 3 questions I'm discussing here simultaneously. All of them are based on X-ray skull. X-ray skull of a patient, it would look as if, I'll just draw the outer table, I'm gonna draw the inner table, and then the lesions which are present will be like, it will look as if there's a map of a country, right? I mean, maybe a map of a country present. So the term that I'm using here before you is called as geographical skull. And I know that you love to read radiology. So can you just quickly comment on the fact that if you ever read this question with respect to geographical skull, which disease are we gonna be talking about? Yes, guys, I think all of you would have prompted it correctly. That would be histiocytosis X. Another feature of X-ray skull that I can mention is the hair on end appearance. That is anyway gonna be seen with hemolytic anemia, so that can be sickle cell anemia, that can be thalassemia. And the next point that I'm saying is actually a repetition. Lytic lesions can also be present in patients who are having osteopetrosis, but in osteopetrosis the bone density will be substantially increased. The bone would be looking like ivory. So when I say ivory skull, I say ivory vertebra. You very well know we're talking about osteopetrosis per se, and that's where again an X-ray skull can be given. So this was just a miscellaneous information that I mentioned for the possible questions that can come with respect to X-ray skull. And now we focus on the main issues that I've highlighted before you. And I would rate the next slide as being so important that I would suggest that even if you're using printed notes, please note down this information with me. So we go a little slow and try to get hang of what aspects are we studying. I'm saying suppose you get a question in which is mentioning that the bone marrow evaluation of a patient is showing plasma cells in the bone marrow, but the percentage value is given to be less than, look at the arrow here, I'm not saying more than 10%, I'm saying it is given to be less than 10%. Then he also mentions regarding monoclonal component coming up, but the value which is given here, the arrow is less than 30 gram per liter. You might notice that in some MCQs he might actually be incorporating this not in liter, but it might be deciliter, so the value will change. I mean, you know, mathematically this is gram per liter, you can just need to convert it to milligram per deciliter, or milligram per milliliter also, depending on the mathematical units that he basically wants to use. But the main highlight of this discussion at this moment is that there is no evidence of CRAB in the patient. You can see that when I started the discussion, I had told you a triad for diagnosis of multiple myeloma, in which though I had not mentioned the mathematical amount of the M component, but I had at least mentioned the fact that the plasma cells in the bone marrow should be more than 10%. And here you are saying that plasma cells are less than 10%. Monoclonal component, as an afterthought, I've added mathematical value less than 30 gram per liter, and there is no evidence of myeloma like lesion. So this very well that I've written is not multiple myeloma, and he will ask you what would be your diagnosis if the following information is given. You will say this is monoclonal gammopathy of unknown significance. Let's do it one more time. Suppose, and I'm gonna do the hard work of writing it. So if you're still not writing it, please try to note it, because only then you will be able to understand the subtle aspects that I'm saying. The plasma cells in the bone marrow of the patient at this point of time are definitely more than 10%. The value I have definitely, I mean, the arrow has changed. The M component, which previously I was saying was less than 30 gram, now it is more than 30 gram per liter. And the third point is still there is no evidence of myeloma like events. Now you will say, sir, what is the point of writing all this down? Because writing this information down will improve your retention capacity to be able to answer questions. Because if there is no myeloma like event, then I cannot say multiple myeloma. Only two criteria are being satisfied. Plasma cells in the bone marrow are more than 10%. Okay. M component is definitely increased, but there is no evidence of, not even a single one of the CRAB features are present. This, your diagnosis would be given as smoldering myeloma. So you can see that both of these are precursors of the disease per se. You first have monoclonal gammopathy of unknown significance. Remember, the arrows will be both less, and common thing between the two will be no evidence of myeloma like event. I hope now you can realize why am I asking you to note it down, because point number 3 in both monoclonal gammopathy of unknown significance and smoldering myeloma, point number 3 is same. But in the first and the second point, the arrows are changing, and you would say, sir, it's such a silly thing to remember these arrows. Yes, they're important for the exam, guys, because if you mess up on something so simple, you would change the diagnosis, or rather upgrade a MGUS patient to smoldering myeloma, or downgrade a smoldering myeloma to MGUS. And the third feature will be, which I'm not writing at the moment, I'll just say it verbally, is suppose I say plasma cells in the bone marrow more than 10%, M component more than 30, both the datas which are given in green are satisfied, 10% and 30 gram per liter. And the third point is evidence of myeloma-like events. That would mean that we're talking about multiple myeloma. And then over and above this, we have plasma cell leukemia, the definition of which I have already sensitized you to in one of the previous slides when I said that plasma cells are now in the peripheral blood of the patient and the number should be more than 2000 per microliter. So I would suggest you to note down the diagnostic criteria of MGUS, smoldering myeloma, multiple myeloma, and the one that I just explained, plasma cell leukemia, on a single small chit. Stick it on somewhere so that this becomes a reflex for you. I mean, when you're reading a question, you're not struggling that whether it is given less than, whether it is given more than, so what should I interpret? It should be at a subconscious level in your brain that you should be able to identify the aspects which I've highlighted here, over and above the miscellaneous aspects of X-ray skull aspect which I highlighted. Now, as far as the prognosis of a patient of multiple myeloma is concerned, lots of advancements have been made. When I was at your age, we used to read regarding, and you would have read about the staging name anyway, Salmon during staging. So in older MCQs, this would still be present, but currently your answer would be international staging system. This is also available as an app. In fact, most of these I would say staging systems are available in a common app like MDCalc, mdcalc.com. If you type it, then in MDCalc you will find a lot of scoring patterns available. So this international staging system is mainly based on two components as of now. One is going to be beta 2 microglobulin that I'm writing is B2M, and second would be values of serum albumin, and based on this we can determine the prognosis of the patient. And now we will study regarding what is the treatment to be offered to these patients, and is it possible to manage these cases with bone marrow transplantation. Now the drugs that would be answered by you in the induction part of management of these patients would be three of them. The first that you will answer will anyway be a steroid, that is dexamethasone. Second is going to be, I would say, a cousin of thalidomide, that is lenalidomide. The third drug that you will answer here is a proteasome inhibitor, that's gonna be bortezomib. So three names are to be remembered for the management of these patients initially. The third one, as I explained to you, should be answered as a proteasome inhibitor. Now, if these patients are transplant eligible, we'll take them up for bone marrow transplantation, but the type of bone marrow transplantation that will be done here would be called as not allogenic. I'm not gonna be asking his first degree relative for a bone marrow transplantation, but I'm going to use this patient's indigenous bone marrow for a bone marrow transplantation. When I will say like this, you will say, sir, how is it possible? On one hand, you are telling me that there are hematological cancer cells in the bone marrow of the patient, and now you're saying you will take it out and give it back to the patient. I mean, you're giving cancer back to the patient. No, guys, what I'm saying is, first of all, I will be using induction and I will kill all these cancerous cells. Once I kill these cancerous cells, I will now be going in for injections of GM-CSF for these patients. When I give these injections of GM-CSF, what will happen? The normal cells in the bone marrow will anyway regenerate, right? So the normal cells in the bone marrow will start proliferating. I will give so much of GM-CSF that now these precursor cells in the bone marrow will not have any space. I'm talking about normal ones, because the bad guys I've killed. It's the good guys that are proliferating now. I'm going to give so much of them, so much of GM-CSF that the good guys in the bone marrow will now come in the bloodstream that I'm going to extract with the process of apheresis. Like you read about apheresis in single donor platelets, lots of you would have worked in a dengue ward and you would have seen that we use apheresis for platelets for SDP. I'm going to do apheresis and take out those normal cells from the blood of this patient and give it back to this guy. Why give it back to this guy? Why not continue with GM-CSF injections? Because GM-CSF injections have a short duration of action. But if I am going to take out some of these cells, give it back to the patient intravenously, they'll go back and colonize the bone marrow. The point is that these cells will be able to colonize the bone marrow again and will make the person disease free. Two situations where we read about autologous bone marrow transplantation is multiple myeloma, which is the topic at the moment, and second would be a relapsed case of lymphoma. Over and above this, every time I have discussed in hematology a bone marrow transplantation, I will always say allogenic bone marrow transplantation. But two situations where you primarily answer in the exam, autologous bone marrow transplantation, and that's obviously normal cells which are being given to this guy of his own bone marrow, because the bad guys were killed by the initial induction therapy for these patients, is the two diseases that I've highlighted at the moment. Now, to trouble you in the exam, there's a possibility that one option could be from pathology, one could be from medicine, one could be from pharmacology, and then he can actually talk about a disease which we do read, but I would say that we just glance through the term per se and don't get into the details of the disease. So what I'm also going to do after this discussion is to incorporate a disease which is commonly read as Waldenstrom macroglobulinemia. The last time I spoke about this disease was in hematology, and I told you that Waldenstrom macroglobulinemia would be producing IgM class of antibody that could be responsible for Coombs positive hemolytic anemia in a patient. I mean, when you will listen to the discussion of cold agglutinin syndrome, you will listen to me talking about Waldenstrom macroglobulinemia. This is definitely a tumor of lymphoplasmacytoid cells. And what these lymphoplasmacytoid cells are doing is that they are causing excess production of immunoglobulin. So like in multiple myeloma, you have a defective immunoglobulin G being produced in the light chains of antibodies being produced in large amount, and IgG is defective. If they talk about IgM defective being produced, it is mainly for Waldenstrom macroglobulinemia. This disease does not have any bony lesions like lytic lesions in the skull or lytic lesions in the spine would not be described. Because there are no lytic lesions, there will be no description in the MCQ for hypercalcemia. Rather, he will predominantly talk about the anemia component of these patients, because after all, in these patients, it is going to be autoimmune hemolytic anemia that would be developing. For management of this condition, the drug that would be answered is not a proteasome inhibitor, it's not going to be steroids, it's not going to be lenalidomide, it's rather going to be ibrutinib. I have at the moment described two diseases before you with respect to light chain overproduction. One is related to immunoglobulin G. In fact, I'll just go back in the slide and highlight it on the very first slide of multiple myeloma, that it is immunoglobulin G which is mainly defective here. And for Waldenstrom macroglobulinemia, it is immunoglobulin M, which is the one which is involved. And then he will ask you regarding heavy chain disease. The ones that I've explained to you till now, two of them are light chain diseases. Heavy chain disease, three terms to be remembered. That would be gamma chain overproduction, alpha chain, and then a mu chain overproduction. The name for gamma chain overproduction would be Franklin disease. For alpha, that would be Seligman disease, and then is mu chain disease. And out of the three, the one that is relatively more common is heavy chain disease. So it's just the names that I would request you to remember, because majority of the questions, they will just maybe incorporate details with respect to the overproductions of the heavy chain. So you need to get the names right for this. And last, I will show you a component of a table from Harrison where that percentage of 60% is described. Let's read this very carefully and slowly. He says biomarkers of malignancy for plasma cell tumor or plasmacytoma would be a clonal bone marrow cell percentage of 60%. And then is light chain ratio. He's just described it mathematically, or maybe one focal lesion on MRI studies, or instead of MRI studies, we can do a PET CT for the person also. So the basic message is that if this entire part that is currently on the slide before you, this is valid when there is no evidence of the person suffering from any CRAB manifestations. There is no myeloma-like event described in the person. Another term that I'll just say verbally, given towards the end in any textbook, is POEM syndrome. So in fact, we can use this opportunity to just jot down the features of POEM syndrome, just in case they decide to ask it. That would be polyneuropathy. Then there would be organomegaly. It could be either a splenomegaly, hepatosplenomegaly, or a lymphadenopathy present in these patients. Then is endocrinopathy. I mean, since they love to ask about these rare aspects, I am talking about the M component now for this disease. The M component would be the M protein component. I mean, why are we discussing this at the moment is mainly because I spoke about M protein. And then can be skin changes. The skin changes can be either in the form of hyperpigmentation, or they can be acrocyanosis in these patients. This is just a small syndrome given towards the end of the discussion of multiple myeloma. So just in case if he decides to ask about it or incorporate it in one of the choices, great. If not, I mean, nothing to be much worried about. It's not a heavy chain disease. It's mainly going to be light chain overproduction, which is going to be asked to you. So these are the details that I would like you to remember for this topic. And in fact, this particular slide, I would rate this as one of the most important parts of this discussion. I mean, if you can get the sequence right, MGUS, then smoldering myeloma, multiple myeloma, then a plasma cell leukemia, I would say 25% of your job is done. Clinical features you have read even in pathology, so no big deal. Some aspects of workup that I've highlighted. So if you're just gonna integrate these facts together, you would be on your way to getting definitely the questions on this topic right. So keep the pressure on, keep working, guys, and I'm very sure that you would be able to get great ranks. Thank you so much for hearing me out.